Okay, we have a good number of people joining. As I've said to others, please put information in the chat box to show who you are, because I don't think everyone knows everyone else on this call. And I think that would really help everyone to give an indication of what people are and what they do. Okay, we're a minute over starting, so I will start now because we have a pretty packed agenda, and I'm sure there's many questions you want to ask and things that we need to go through at this meeting. So I think I'd like to start if we can. My name is Paul Carter. I work in the Commitment to Carers programme, which is within Experience of Care of NHS E&I, and we work on specifically on work relating to carers, into policy and carer involvement and carer voice, and so on. So that's a really important area for us. I'm ably assisted on this call by Ellen Bang, who you can see as well, and by Ian Shaw, who will hopefully be watching the inbox in case there's any questions to put in the chat box, shall I say, we need to pick up either at the meeting or afterwards. Okay, Hayley, are you able to put the agenda up? Okay, hopefully everyone will have seen the agenda, and unless there's anything on there that shouldn't be on there, I'm going to follow that as closely as I reasonably can to try and cover the areas that people have, where people have responded. There's I'm going to include that in what we say. But clearly, if there are other questions that arise, please put them into the chat box or contact us afterwards if they don't occur to you at the time. This is an evolving process and we really want to involve everyone in it. And I think it's really important that we can do that. Can you put the slides up now, please, Hayley? Now, the first thing that, while Hayley does that, the first thing that I want to say is it's really, I'm delighted to be working with Healthwatch, local Healthwatchers from across the country. It's not something we do directly that often. We do speak to Healthwatch England from time to time, but we don't necessarily work closely with local Healthwatchers. So I'm really pleased to be working with you on this particular piece of work. And to welcome all 7 of you from around the country, which will bring a richness to what we're doing around carer experience, specifically around discharge from hospital, but also experience within hospital and post discharge from hospital. I think the things I need to really start with is why we're doing this work. Other organisations, including Healthwatch, British Red Cross, and Carers UK, have done surveys around carer experience, particularly during COVID and pandemic. And I appreciate we're not through that yet entirely. But our focus here is on that, but on the more specific around, without getting too jargon related, around changes in discharge pathways. With the introduction of pandemic measures, all trusts moved to a discharge to assess footing, which for many that was new or something that they only operated during winter pressures, or for others they've developed that into a business as usual discharge process. What we want to find here is the carer experience of that functioning of that discharge process and pathway, as it looks like it will be continued. If you look at the latest health bill that's going through Parliament, that will become the normal way of discharging patients from hospital. So it is entirely relevant to what happens going forward. Without getting too bogged down with either the white paper, social care white paper that is being worked on at the moment, or the health bill, and certainly Carers UK and Carers Trust are very on that, and we are, as much as we reasonably can be, but we can't be saying or doing what carer organisations can on that, specifically around potential of erosion of carers' rights around discharge and how that might work within that process. So our focus is on how it's working for carers and the experience they're having with the new pathway, and how we can understand how that is working well, how it's not working well, and how it needs to work going forward in terms of setting a benchmark, setting best practice as to what should be measured, what is being measured, and how we can measure that as we go forward. So next slide, please, Hayley. I've just put up here our strategic objectives, how this piece of work fits in with what we do. I'm not intending to read that out. The key thing for us is around better outcomes for patients and specifically unpaid carers, producing a more carer-friendly NHS at every touch point where patients, carers interact with the NHS and its various forms. How to support carers better during that caring journey, which will change during that process. And really to support carers not to go into crisis themselves, because they can't care for people if they're going into crisis themselves. And in terms of more strategically as well, we want to look at unpaid carers as a vulnerable community in their own right, and caring as a social determinant of health. And this fits very much into the new structures that are being worked up that are linking NHS or health and social care, and working in a more system-wide population health approach. The other thing that really helps us with the carers agenda is that carers are all over our long-term plan, which really gives us a basis for working. So next slide, please. So one of the key questions that has to be asked right at the beginning is, who are carers? And Carers Trust definition, it is up there. I think what we should say clearly is that is a reasonably wide definition, but it is really clearly to be caring for family or friends that is above and beyond normal parenting or normal family support. So where the cared for person either has illness, disability, or mental health problem or addiction that they could not cope with living sustainably on their own without that support. And I think the thing that is really pressed home with unpaid carers is that they are not paid, that the work they do is not paid, they're not care workers. What they do is something they want to do, but it can have an impact on their health, which studies have shown clearly, both physical and mental health, and their ability to earn if they are working age, or if they are young carers, their ability to benefit from education. So carers come in all ages, from all walks of life, and their journey with the cared for person is different for each of them. And I think the experience interviews you will see will be many and varied in terms of how that works. For the elderly, social isolation, digital exclusion is a very big issue, and I think the pandemic has shown that clearly. And for working age, it's really juggling work, parenting, and caring all together can be extremely difficult. And these people don't normally identify as a carer because they see them identify as a working person and so on. So they would not answer the question, are you a carer, necessarily as being a carer. That's not how they identify themselves generally. For the young carers and young adult carers, there are specific issues around obviously education, access to education, and also pandemic has shown around mental health particularly. So that is the definition of care, and these are the people that we need to be approaching for these experience interviews. Next slide, please, Hayley. The other thing I should have mentioned perhaps is that the work that you're doing and we're doing fits very much into other work that is happening at the moment around integration within health and care systems. For example, in the Better Care Fund, National Condition number 4 says that there is assurance of plans for improving outcomes for people being discharged from hospital. So care experience very much fits into that. There's also work happening around key lines of inquiry for the CQC around the work that they do, assurance of the overall ICS platforms and how that works. So this could feed into that element as well. And I think, as I said previously, there's a work just starting at the moment on the ADAS, so Association of Directors of Social Services have a Carers and Safeguarding Adults Advice Note, which goes back to 2011, and that's just about being updated. So again, it can inform that work as well. So this work is definitely timely around development of new integrated care systems. It's very timely in terms of the health bill and potential changes in discharge success and discharge pathways, and also around collaborative working more generally. So whilst it could be said it's bad timing because it's winter and it's we're still in a COVID pandemic, but some of these things are happening anyway. So getting the carer's voice into that won't necessarily wait. So we need to work and adapt as much as we can to do that. So carer selection, I think we've kind of covered that a little bit. We're looking for at least 10, and I should have said they're semi-structured interviews, not structured interviews with carers, and hopefully in the guide we've given some indication of what that actually means. Key thing for me is that it's carers with recent experience. So I think it's very clear that after 6 months, people's memories and what was important to them at that experience can change. We can't have it too close to that experience because people will be too focused on that potentially. And particularly some of the post-discharge potential issues won't necessarily have happened if you make it within a small number of weeks after discharge of the cared for person. So that's who we're looking for. I think the other thing that we need to always have in our minds is around the diversity elements of that. And I'm not going to be too prescriptive about this. What we should try and do, though, is to choose carers that are reasonably representative of the populations that you serve where you can. So to use a silly example, I wouldn't want all the interviews to be with 75-year-old plus females from a market town, shall we say. Because of the numbers that we're doing here, this will not be representative, but we wanted it to be broadly representative of the populations that you cover, so that between the 7, we get a richer view of experience from people of different backgrounds and different communities, if that makes sense. In terms of engagement method, I probably should have been a little bit clearer. I believe this should either be done online if that's possible, or face-to-face if that's possible, although you will need to follow whatever COVID guidelines are in place, and these things change all the time. I think it would be difficult to do this properly by a questionnaire, although it could be done by telephone. That is the other option that you could do it. So either video conferencing, telephone, or face-to-face. I don't think a postal questionnaire would get the information or develop the rapport and the interplay that you would want to get in terms of what we're trying to do here. So this is ultimately qualitative research, not quantitative research, that we're doing here. It needs to be rigorous enough to have value and to be recognised as that, but I'm not expecting it necessarily to be at a master's level or necessarily publishable, if that makes sense to you, in terms of what we're trying to do. So next slide, please. By the way, I'm recognising I'm talking rather a lot. I will stop in a minute and let others say something. So the interview guide I have circulated, and hopefully that will be helpful. I think I've had some responses to this, and I will try and pick up some of those responses in this. It is a guide for you to help you focus the questions and the topics. If you are able to get upfront information, then that will make it easier to understand both the experience of the carer, which I think is relevant to what they're seeing, and the health situation of the cared for person. So how often have they been involved in seeing the cared for person in and out of hospital, for example, is relevant to their experience this time compared to previous times, and how recent that would have been. And they would potentially also understand systems in different ways to it being a first time. So we need to capture that. In terms of the prompt questions, they are just really to help focus conversations if they're struggling to develop. Obviously, with a semi-structured interview, you should go with what people are saying in the words that they're saying it. As many of you will have had a lot of experience of this, I'm quite sure, and keep that flow going, because that really helps. I think the only caveat I would have with that is that what we're trying to do here is to provide information for improvement in quality, to understanding what carers think is important and how we might measure that and identify that. We are not trying to solve the particular case of the individual that was experiencing this particular episode or event. That's not what we're trying to do here. It's a wider picture that we're trying to address. Diversity we've kind of covered already. So it needs to be broadly representative of communities that you serve, as much as you reasonably can within the envelope of people having had experience within the last 6 months. In terms of topic areas, one of the things that has been picked up is that I think we probably need to put a question in or adapt to pick up aspects more clearly around mental health of the carer and of signposting and so on to do with the experience of the cared for person as well, because clearly that is something that has become more important and is very important how that gets picked up. Communications is something that will always come out of these sort of interviews. I think my question around communications is we need to be quite specific. It can become very easily a catch-all area. So we need to be specific around what that communications issue is. Is it an individual one? Is it between teams? Is it between professionals? Is it between different organizations? Is it around timing? We need to be reasonably specific about what the communication issue. It's not just a large area that we can't define at all. Service coordination, I think, is fundamental to getting discharge right for many people, particularly if there's follow-up, either with primary care or with social care in terms of physical changes or needs. And this is where voluntary sector organisations get involved as well. So coordination is certainly something that we would be looking for. People have also asked around the data protection elements of this piece of work. I should have probably picked that up earlier. I would have to check with Healthwatch what your data protection is, because as an organisation we have that. So how people are identified and how the information is used, clearly we have to tie that down very tight, so that we can only use it in pseudonymized form as we go forward, and we can only use it specifically for this particular piece of work. Another question that's been asked is around use of the feedback, and I think, as I said on the, as has been said on the project confirmation form, as this is a national piece of work and you're all doing it individually, all to the same prescription, if you like, we would like the opportunity to be able to assemble that and come with our national findings before you start using your locally based findings, which will be interesting and useful locally, but they may not mirror exactly what the totality of the information that comes out in our final report. So if you could respect that, I would really appreciate it. So I think I will probably stop there for a second and see if anyone wishes to say something on that, and I'll come back to other details a bit further forward. I'm hoping I haven't stunned you all into silence. Hello, sorry, I can't. Diana, sorry.
Yes, thank you, Paul. It's just a very quick question, really, just a kick start. But I'm wondering, because you said you want the interviews recorded. What if they don't want to be recorded? What if they refuse that? Do we still go ahead with the interview?
Sorry, I should probably have said a little more clearly. I mean, I think the reason why recording is usually best is that obviously people talk at a rate, and unless you've got shorthand or are able to have an additional person taking notes, it's quite hard to do that. And the detail that people come up with is not necessarily, it needs to be recorded in the context of the way they say it, because that can be important to what is important or not. So I think ideally audio recording is the best. If people refuse that, then that makes it more complicated. I think the other reason for recording is that if this is something I was going to talk about in a minute, if we get it, transcribing it isn't easy, and it's better, in my experience, to use agencies that are well versed in doing this, so that then we get comparable interview information across the 70 interviews that will take place. And that will make it much easier then to do the thematic analysis based on the transcribed interviews. So I'm probably not asking your question quite as directly as you'd like, but ideally audio recording would be best if that is possible.
Yeah, okay. I can see that. I certainly can see the benefits of it, and I understand for consistency as well that that would be ideal. I'm just wondering if we arrange the interview and we go to see them and we say we'd like to record it, and they say, oh no, that's not going to happen. So I think probably the best thing then to do is to make sure they're aware that they will be an audio recording prior to actually conducting the interview or arranging that date with them.
I would like the balance of the 10, and hopefully as many of the 10 to be audio. If you get a very interesting experience that will not allow that, then please record it in using paper and so on, if they're happy to do that.
Okay.
I wouldn't want it to not be in because of that, but I wouldn't want to limit. I wouldn't want that to be the default. We'll do them by paper as a first choice. To me, it's a second choice because of the repeatability of it.
Yeah, you wouldn't want to preclude them.
No.
Based on that, if they were a good
exactly. If they've got some really good things to say, then we wouldn't want them to be excluded because of that. No.
Okay, right. We'll bear that in mind. Thank you.
Anyone else?
There's a question in the chat box, Paul.
Oh, sorry.
Yep. Anne has asked if you could confirm unpaid carers does not exclude those on carers benefits.
Okay. And unpaid carers receiving carers allowance are unpaid carers. So if they're receiving the carers allowance that comes through DWP, they've gone through a process to identify them as carers. So absolutely they can. What we're trying to separate out is care workers from unpaid carers, if that makes sense. So unpaid carers do not get paid for the care they are providing, but they can, if they wish to go through the process with DWP to get carers allowance, then absolutely they are carers, unpaid carers, in our eyes. Anyone else? I think the only other thing I would say around identification, it's come on apace with the fact that unpaid carers were put in priority group 6 for vaccinations, and obviously the latest booster one has them all over that, and there is a process for identification of them. In terms of unpaid carers, they've been identified either through DWP, through local authority records, through care organisation records, and through being flagged in primary care systems. So that has developed and expanded, and more people have identified now as carers, particularly working age people and people from communities that wouldn't necessarily have recognised themselves as carers previously. So that number of people has actually expanded. Sorry, another hand up. Anne. Sorry, Annette, sorry. Some short form on mine.
My question, would there be a minimum on the age of the carer?
No, if they are producing an unpaid care, if they are meeting the definition, they are a young carer with a sibling or with a parent that they do provide caring for, then they should be included, yes.
Okay, thank you.
There's another question in the chat box,
Sorry.
Paul, if you can see it, or do you want me to?
Yeah, I've only said 6 months is where people's experience tends to reduce or become more muddled, shall we say. Then I don't want it to be too recent, only to capture a lot of issues that other surveys have picked up is around coordination after discharge and follow-up after discharge not being great. So context you said May is fine, absolutely. I just don't want it to be the week after or 2 or 3 weeks after, because I don't think people would have settled into what the situation really is and how they their experience of it. In terms of incentives, Chris, I've seen that that is really up to you to work out on a localized basis how that works and what form that might take. In my conversations with your colleagues in Healthwatch England, I gather and other surveys that we've got involved in, some people you do use incentives, some people don't, and what that incentive is and how it works is different elsewhere. I think where you are using incentive for people to give up their time for an hour and potentially more, then that's really up to you. I think if you're doing pure research, we would need to make it very clear on what basis that was done and what it was, and have that acknowledgement at that time. I think probably what you're talking about here is just really to recognise people's time rather than to get people on board separately. So I hope that answers your question, Chris. In terms of whether to use community or mental health settings, yes. This is really what happens at discharge from hospital. I would expect most experiences, because just by dint of numbers, will be from acutes, and I think they've seen the most change potentially with their discharge pathways in the last 2 years, possibly more than community or mental health settings. The other thing perhaps I should say is that whilst some of the experiences that people will almost certainly produce will mention specifics around COVID and COVID related issues, we don't want to get completely bogged down by that. It is relevant, but what we're more interested in is how we improve the experience for carers, how we measure that, what quality looks like, what best practice looks like for carers at discharge, and the fact that discharge to assess is going to become the norm in the future, how we do that. So if they are COVID specific around ward changes, around vaccination and around difficulties specific to COVID, they're relevant to the experience, but it's not something we particularly want to focus on in our learning from this, if you like. Other pieces of work have covered that very well, and certainly Carers UK have, and Healthwatch and British Red Cross have done that already to some extent. Sorry, there's another hand up. I can't see who it is though.
Natalie?
Hi, thank you.
Natalie.
You've got on the screen there transcription and thematic analysis. I'm just back from leave and I'm not as on point with the latest guidance, but I didn't think we were doing any thematic analysis. Am I completely wrong?
No, we all do the thematic analysis. This is really on the next slide actually, but don't put it up at the second. But sorry, it's on this bottom of this slide. Sorry, the thematic analysis will be done centrally, so that we are doing the same and we're getting the coding and all of that will be driven by the way that will be done by an independent organisation and to a prescription that we will give them based on the information that we have. The transcription side of it, if you have people that you've used to do transcription services, then please let me know who they are. I haven't chosen a service to do this yet. My interest is in trying to make it comparable and doing it in the same way. And I know that transcription is hard to do well or hard to do uniformly because everyone does it slightly differently. So it may well be that it'd be better to do that ourselves if you like. But if you have people that you know you work with, please let me know who they are.
Okay, two more quick things then, and one is
Sure.
related to that. If people do use a centralised transcription service,
Yep.
we have got one, but we're considering
Okay.
one. So if people wanted to share that, obviously I don't want there to be competing availability, but that would be really helpful.
Sure.
The other one is just thinking back what you were saying about really being clear and trying to move away from experiences that are most likely to be affected by COVID if we're thinking about the future. So, for example, if visiting wasn't an issue in the way it has been, and it has reduced footfall on the wards, I'm just thinking back on a couple of more recent experiences. Actually, that really still has played a role, and I just need to kind of be thinking about how we would get round that, or how we're going to differentiate that. So I guess in this, if we're meeting monthly, that will be something that might come up again.
Yeah, I mean that is going to be different for everybody. I mean, if you're looking at the last 6 months, obviously the number of people in hospital with COVID currently is quite high. It's up back to March levels, in fact. But if you're looking back 3 months and a bit longer, those numbers weren't quite so high. So how much that has impacted on people's experience is hard to judge. I think all I'm trying to say is that the learning we're trying to get out here is not specific to COVID. We want it to be more sustainable learning as we change and as discharge pathways develop. I want it to be more in that sphere if we can. That's not stopping people talking about COVID. They can and will, and it may be relevant to whether conversations were had or whether, the other thing that I probably should have said more strongly at the beginning is that we're not looking for bad experiences here. We're looking for good as well as bad. We learn from good experiences as well as from bad experiences. So it could be that some people have found the processes better because they've been shorter and they've been better discussions, coordination between services in some cases. So we shouldn't come into this assuming it's all bad.
No,
it won't be for everybody.
No, but in the same vein, my other concern is that, for example, in Cornwall at the moment, we only in the last week or so had to declare a critical incident. So we know that staffing is an area of concern for everyone at the moment, but it is of particular concern in Cornwall in respect of health and social care. So I imagine that would also kind of skew things, say if we were doing this, I don't know, in 2 years' time. how do we sort of factor that in?
Well, I'm hoping the bigger picture elements will become clearer in the focus group session, because then we're trying to extrapolate how care experience informs what is happening, how it's a barometer for what is happening, why it should be measured, why it should be listened to, how we can see what good looks like and what not so good looks like. So bringing together a wider group of stakeholders will hopefully inform that wider discussion around how things could be, should be working better, and how things are working well, and what markers we have for showing that it is working well. And it is definitely my belief that some markers around care experience will show where discharge is working well and where it is not working well. And I think that will give people some very valuable and useful information going forward, because currently the focus is much more on metrics that are, in my estimation, easy to measure around bed days, discharge times, and readmissions, which give some indication, absolutely, as to how flows are working, but it doesn't necessarily provide a very clear window into the experience of people going through those processes.
Thank you.
If that is clear.
It is, thank you, that's really helpful.
There's a number of questions, Paul, in the chat box.
Yeah. I think with the transcripts, we need to talk about how that's done, or recordings. Let's get back to that. It depends how we do that. I would ask if people do have current transcription services that they let be known to me, and we need to work out how to do that collectively, and it's something I will need to come back to you on. Question around the mental health charity. That's not something I've entirely considered. It's something I need to think about and work out how we might do that, should it be necessary. But certainly local organisations might be the best. Can I come back to that one? If you don't mind, time is rushing on. Can I come to the next slide, please, Hayley? So we've segued into the focus groups. We want to use the lived experience that we're gathering from carers and other information from other surveys, and bring that into a room, albeit a virtual room, with relevant representatives from local authority, social care, hospitals, be they carers leads, be they quality leads, be they nursing leads, be they discharge team leads, and ideally some health commissioners, if at all possible. And I've already had some pushback from one organisation saying that our commissioners won't attend before the end of February because of winter pressures, etc. I think, as I outlined at the beginning, I don't think this is something we can actually wait for. It is needed, and things are marching on. If we don't get the carer's voice into some of the metrics and way of viewing quality at discharge, then we will that opportunity will have gone or got more difficult. So I don't want to exaggerate that, but I think where we can, we're going to have to get around that as much as we can, and to get those people in a room, because I think then we get the context, we get the importance of that. And as I said earlier, in terms of the Better Care Fund money, systems are going to have to show how they are improving outcomes after discharge. So this work is all relevant to that. So those people in that room should think there is a value for spending the time necessary to attend the focus group and to be part of that process. In terms of the mix of participants, clearly that will come down to local circumstances, but we would like to have representatives from health and social care, I see local authority, be they carers, leads or whomsoever. And I think it's really important to involve voluntary sector organisations as well, because in many cases they are commissioned by local authorities and are very involved and have very good links with known carers in localities for that. I think having them in the focus group will really help to work out what the next steps are and what needs to be done. And I appreciate timing will be tricky. Whenever you set the timing, it will be tricky. If we need to be able to complete this and do it before comfortably before the end of March, so we have a bit of leeway, but we don't have lots. And as I said before, the timing is really quite important as to how we might influence some of the processes going on at the moment in terms of what happens going forward. Next slide, please, Hayley. So we still have a few minutes. We have a little bit less than 15 minutes. But I think this has been a really quick run through. It's really been helpful to have everyone on the call, and I really look forward to your follow-up and feedback. There's certainly some things that I need to come back to, particularly around transcription services, and I see that Chris has put around translation services as well, which I appreciate is another level of this, which will add some level of complexity as well, which we need to consider. And you're right, if we're working with young carers, and particularly if they are younger than adult age, then there are particular restrictions around how that's done and so on. So we need to look at what the guidance is around that, and I'm sure we can put together something around that as well for you. I hope this has been useful. And obviously one of the things that we need to decide on this call is frequency of meetings. And I don't want to have more meetings than we need, but we clearly need to talk to each other and as a group develop this over the coming days and weeks and months. So I was thinking probably next meeting in around about a month, but obviously there are follow-ups that we will pick up from this. But what are people thinking on that? Can I see any commentary on that? Is that helpful? Do you need one in 2 weeks' time? Is a month too long? Okay, one person saying a month sounds fine. Any other clues? Minimum of monthly, okay. Fine. Because we can communicate without having to be directly in a room on a call. Okay, so I'm going to go with a month, and we'll try and find a date. Is this time of the day a good time? That's the other thing I was going to say. Or is it not a good time? Sarah's asked the question in terms of final version of the interview things. The other thing that, sorry, Sarah did ask me this question that I haven't really picked up on. In terms of the interview guide, it's very much a guide. What I've put in there around the diversity questions is a standard form, NHS form. I wouldn't want you wouldn't necessarily have to go through that line by line. If you've already interacted with the person, you would be able to do that much more quickly with them, I believe. The other thing that Sarah's done, and I absolutely agree with, in terms of getting a report and getting an interview flow going, it's sometimes much better to do the diversity questions at the end. To say we are not governed by having to do a very extensive diversity guide here, but we really need to be able to show that the people being interviewed are broadly representative of the communities that you serve. I think that is important for the richness of the information we get, and equally from an health and inequalities viewpoint, as well as from a diversity point of view. And I think we need to respect that in all the work we do, which you understand. So good time. People seem to think it's a good time. So I will stick with 1:30 to 2:30 in around about a month, and we'll put a marker out for that. So we've whizzed through fairly quickly. I'm sure I've missed a few things, and I'm sure you've got more questions, but we have about 10 minutes. You can ask 9 minutes to ask more questions. Either that or I'll give you some time back. So we have questions. Diana.
Thank you, Paul. Yes, just a very quick one about that cross-section of our community.
Yes.
I'm just interested, because here in Central Bedfordshire we're mainly white British. That's our population in general. So, and also what concerns me is that when we interact with carers, apart from young carers, which let's just separate them out for a second, but most adult carers generally tend to be older people.
Yep.
And so we're going to end up, that this is what I'm concerned about, we're going to end up in Central Bedfordshire with white British older people as a kind of, you know, the cohort of carers that we're interviewing. So would that be an issue? Is that a problem if that's what we end up with?
No, the key thing for me is that it's representative of, broadly representative of the carer population within the population that you cover. I mean, other areas will have very different population demographics, and I think it's difficult to be too prescriptive about this. I'm going to use an example of if you looked at health watches that are a complete county, they will be huge differences across any county, generally speaking, and the wider the geography, I just don't want, in where there's a very large geography, that everyone comes from one particular town is of a similar age or a similar gender, because I don't think that would give us the coverage that we could get. The fact that we've chosen health watches from all around the country will hopefully give us a different community to come of experience to come from. And as you say, many carers or people that easily identify as carers are from older age groups. But I'm hoping that particularly with the vaccinations and with a lot of more publicity around vaccination, that more people identify as carers would mean that you could bring in people of lower of working age, for example, some. But in terms of communities, you are stuck with your demographic, and I don't think you need to be going to the nth degree to get a different demographic. It just needs to be broadly representative.
Okay, that helps. Thank you.
Erin's asked deadline for transcripts. I want the reason for transcripts in by the 7th is that we need to have done some of the initial understanding and analysis before the focus groups happen, so that individual experiences for each of your 7 areas can be replayed to some extent, and the themes picked up within the focus group sessions, which need to take place in February. So the reason for that relatively tight deadline is so that we have time to do that, and so that the value of those carer experiences can really illuminate the discussions that take place in the focus groups. That's really the value of this, both at a regional level and in the final reporting of this. Is at the end of the day, we want carers' voices to be very clear and how they inform choices that are being made around what quality looks like at discharge, etc., as I've tried to explain. So I will try and keep to those deadlines if we can. If we start slipping deadlines too soon, we'll find we're pushing well into the year, and we don't really have that optional opportunity. Any other questions? We have a few minutes. Okay, I won't prolong this any longer. I'm slightly surprised that we've finished a few minutes before, so you've got 3 or 4 minutes back before, no doubt you have other meetings. But thank you very much for contributing both before the call and on the call, and obviously after. And I hope that you find this as valuable as we do in terms of a process, in terms of importance of this project. And thank you for the opportunity to work with you. And I'd like to thank Helen and Hayley for supporting this call as well on my behalf. And I can see Ollie there from Healthwatch England. Thank you for the conversations and the support that you've had in this overall process. And I'm sure we'll be speaking again, and we'll put in the diary for a month's time. And I've now taken another minute of your time, but you've got 3 minutes back. So speak soon. Thank you very much. Thank you.
Brilliant. Thanks, Paul. Thanks, everyone.